just mind the gap because it's a very small area where we'll be working out, and step in very carefully and do everything very gently. So this is the Cambian's triangle, which actually gives access to the disc or the epidural space through a very safe zone. And there are many structures which are intricately placed around or within this triangle, which actually gives rise to any complications in the post-op or during the surgery. And to add to the problem, I mean, basically, especially for the beginners, is a little lack of understanding of the foraminal anatomy that poses difficulty. And on top of that, you know, the difference in the angle of vision and the angle of instrumentation in that very small area, that also causes difficulty. So whenever we enter the foramen in the disc, it's more like the first picture, you hardly recognize anything, and slowly and steadily when you clear up the tissues from there, the things becomes clearer and you become more confident navigating in that area. So the best way to treat complication is to prevent it. So there are many scenarios, I mean, different complications you may land up into. I'm not discussing on the incidence rates, because if you land up in one of these complications, it's 100% for you and the patient. So talking about the neural injuries, like exiting root or DRG, traversing root. So there are two occasions where we could damage these nerves. First, when we are getting the access through the access needle into the foramen, which is entirely under fluoroscopic guidance. And secondly, when you are putting the working sleeve there, the bevel should be kept away, facing the axilla of the exiting root. If you are taking the approach needle too flat, you may directly hit the traversing root as well. So it's very important that you follow the protocols and the guidelines for the approach. Then focal nerves or conjoined nerves, these can also be damaged, but these are very rare phenomena. So you need to understand the basic tissues in the foramina when you are seeing it through the endoscope, and not to indiscriminately cut everything which is coming your way till the disc. All the more, whenever you approach the foramina, it's more important that you do not infiltrate any local anesthetics inside the foramina unless until you reach the posterior annular margin, so that you ensure that the trajectory you have taken is entirely free of any nerve, and you then infiltrate and go inside the disc. Dural tears could be there because of some thermal or mechanical reasons. Thermal in the sense, many a times when you remove the large fragments from within, it bleeds immensely at that point in time. So indiscriminate, use of radiofrequency bipolar cautery in that area may lead to some injury to the dura as well, because it's exposed through the rent around this area. And though it's pretty safe, but excessive use around the neural structure does cause some dysesthesia in the post-op. Mechanical reasons could be because of migrated disc or central herniation or chronic pathology or extruded fragments, because it could be adherent to the dura. And many a times patients do not disclose you that how long he has been suffering from, and many a times actually you are trying to tease out the fragment from within the disc, so it might tug the dura and it may injure the dura as well. Another important thing is if a surgeon is very aggressive, then also you may invite these problems. So vascular injuries are though rare, but it is quite possible. The radicular artery, especially when you are venturing out around the axilla of the exiting root, from where in the subpedicular region, especially during foraminoplasties and all. So during that time, you need to be very careful that you do not end up injuring the radicular artery. Though mostly it's not seen very clearly, but you could see the pulsation around that area in the axilla of the exiting route. Epidural veins are bleeding through epidural veins can be controlled with proper coagulation of the through bipolar radiofrequency cauteries. Retroperitoneal hematomas, epidural hematomas, flex tip deformities, these all could be possible, especially in patients who are having some coagulopathies or are on some blood thinners, especially in chronic renal failure patients. They ooze like anything many a times, despite normal investigation parameters. Visceral injuries are quite possible if you are taking too far lateral approach, or you are too flat to the foramina. Then you may end up injuring the breaching the peritoneum, or you are too flat and you have breached the anterior disc margin then also. So it's very important that you always check your needle placement or the approach in AP and lateral views. It's better to hit the bone first and judge your position, and then you manipulate your needle so that you could reach in a safer zone. Infection is relatively rare by virtue of the constant irrigation we use, but still it's not it's very uncommon, but you need to be very vigilant about the symptoms of discitis in the post-op. All the markers should be done at the slightest suspicion of infection, and treat it aggressively. Initially, the patient might be helped with a endoscopic lavage, because many a times we refrain from intervening immediate in the post-op if the patient is having discitis. But it's a very good thing that if you could just lavage the disc and put the patient on a very IV antibiotics for quite some time, the patient recovers very nicely. But as a last resort, fixation and debridement of the disc could be done. Neck pain, headaches, convulsions, blurring of vision, these are all irrigation fluid related issues which you might face. The irrigation fluid pressure need to be monitored, as the epidural venous pressure is mostly less than 15 millimeter mercury. So a pressure higher than this almost gives you a very clear and magnified field through the fluid. But with spurts of high pressure, if you have to see the bleeding point and coagulate it, mostly gravity assisted float suffices the thing, and you might not need too much of a pressure for irrigation. Bradycardia, it's mostly when you are about to tap the annulus for inside-out approach. So that time you need to be very vigilant. The anesthetist should be informed that you are about to tap the dilator in the disc, because many times because of vagal stimulation, the patient does end up in bradycardia. Incomplete decompression, it's more like, you have picked up few culprits and left one kingpin inside. So it does happen many a time. The patient end up having symptoms even in the post-op or in the after 1 week of surgery, that the patient he complains of the similar kind of pain or a different kind of pain which is still there. So missed fragment or remnant lateral recystinosis or reherniations are quite possible, especially because of migrated disc.
Can you just come to the last slide?
Yes, sir.
Yeah.
A large it's almost
conclusions.
So instrument malfunctions and level selection is very important, that you should always confirm in AP and lateral, corroborating with your MRI film that you are at the right place. What could be better avoided in PLD is subjected to the skills of the surgeon: central canal stenosis, calcified disc herniation, and migrated or large herniation at L5S1. So points to ponder: just be gentle in that area, be patient, plan and execute in a very well thought out way the entire surgery, and confirm your location in fluoroscopy whenever you are in doubt, and don't panic. Thanks.